Hello, good afternoon. Good afternoon. My name is Doneen Williams. I'm an organizer for the Harvard Union of Clerical and Technical Workers, and I would like to welcome you here and thank you all for coming out today and braving the weather. I'm really glad that you're all here. Last year for the union's birthday, we did a series of learning workshops to celebrate our 25 years, and it was so popular, we got such great feedback that we decided to put this panel together today, especially on healthcare. It's something that's on the top of our minds, and with so much changing so rapidly, there's a lot for us to stay on top of. Today's presentation is being recorded, and we will link to it on our website later this week. If you want, you can join the conversation on Twitter. We will be at HUCTW, if you'd like, if you're a tweeter. I am not. When our speakers are finished, we'll have some time for questions, and there will be ushers in the aisle who have microphones, but they also have index cards. So if you'd like to write your question down and send it to an usher, just look for somebody wandering up and down the aisles with index cards. At the end of today's session, we will be giving away a Fitbit. So if you've got a tag, a ticket on your way in, we'll do a drawing for a Fitbit so we can all track our steps together and stay healthy. I'll turn it over now to my colleague Bill Yeager, but I wanted to say thank you again for everybody for coming out today.
Thanks, Doneen. Healthcare is very expensive in this country in 2014. High annual increases in medical spending galloped along for many years until they slowed down somewhat starting in 2010. There's an interesting debate going on among health economists about the cause of smaller rate increases in recent years, about whether the slowdown is the result of recession economics or of structural changes in the health system. But that's not the argument we're here to settle today. There is no debate that we are all struggling to pay for health care. For government, for employers, and for families, paying our medical bills is more difficult for all of us than it was 10 years and 20 years ago. The majority of Americans get their health care through work, so we're focused today on the question of how employers or working communities can work to control the cost of health care. Most broadly, there are two types of strategies that have been developed in recent years for slowing the growth of an organization's health care costs. One approach is to increase patient cost sharing with co-payments, deductibles, and co-insurance. These kinds of changes will shift costs off of the employer and onto patients who pay more when they receive health care. Increased patient cost sharing leads patients to make different choices about whether or where to seek medical attention, and there is some difference of opinion among economists about the medium and long-term effects of those decisions. The second type of employer effort that has emerged in the past few years is in the area of reducing total health care cost through programs that aim at better coordination of care, redesigning the health care delivery model, and improving employee health. We're going to focus our attention today on some innovative efforts in that second area. HUCTW issued a report in September called 7 Good Ideas for Bending the Healthcare Cost Curve, and there are copies on the table in the back. With that report, we're trying to begin a conversation about exploring some of these programs. We have a fantastic group of panelists today who can take us a lot further in understanding some of the innovations that are going on currently, about what works and what doesn't, and how some of the ideas relate to each other and to what's happening in our healthcare system. I'm going to stop talking now because I know we're all eager to hear from them, and I'm sure there are a lot of people here who would like to ask questions or to make comments. So now just very briefly to tell you who our panelists are. Dolores Mitchell, from whom you'll hear first, is Executive Director of the Massachusetts Group Insurance Commission, or GIC, which manages health plans for more than 400,000 state and municipal employees and family members. We're really looking forward to hearing from her about what's going on at the GIC. Ruchika Fernandopoulos is a clinical instructor at the Harvard Medical School and the CEO of Iora Health, which is a really interesting organization doing innovative things in the delivery of primary care. And it's great to have him here to tell us more about that. And Meredith Rosenthal is professor of health economics and policy at the Harvard School of Public Health. It's terrific that she can be with us today to help us understand how some of these ideas fit together and what's happening more broadly in healthcare. So we're going to hear first from Dolores Mitchell.
Good afternoon. Before I start, don't count this on my time. I want to thank Bill and Janine and Rachel. A lot of people just ask you to come and speak, and then you're left to fend for yourself. But tender, loving care and what to do and where to go and so on. I was here at this institution so many years ago, I'd forgotten where it was or how to get here. So, in any case, okay, you can start the clock now. I accepted the invitation to come and speak in today's panel primarily, well, first of all, because I allow myself one liberal moment a week, and you're getting it. Because Nancy Turnbull, who used to be one of my commissioners and is now on the faculty across the river, the Fenway, not the Alston area, asked me, and is a great fan of Nancy's. I always try to do whatever it is she asks me to do. I probably would have said yes later on when I found out that the other panelists were going to be Rushika and Meredith, since I'm a great admirer of both of them. And finally, I'm always pleased to have the chance to share with a new audience, instead of the usual suspects, some of the things we at the GIC have done to try to achieve our two main goals: getting our arms around the healthcare monster, the healthcare cost monster to be specific, and doing so while simultaneously improving healthcare quality. We've been at this for 25 years, and while every program we have implemented has in fact worked, at least modestly, not one of them has really gotten into the underlying structural defects in our existing system of medical care, if in fact you can complement it by calling it a system. Let me show you just 6 quick slides that lay out the problem. I'm going to do this very fast because this is my least favorite means of communication. U.S., up there in the upper stratosphere in terms of cost compared to GDP. Second one, oh, I should have had you go over there, shouldn't I? That's Massachusetts, being number one, over here on the right-hand side. Being number one is not a compliment. Number 3, this one really bothers me because my agency is part of the contributor of the bad side and also part of the sufferer on the good side. This shows you in the state budgets over a period of 5 years how much the medical spending that we do out of the state budget has negatively affected every other single thing that contributes to health, just as much as medical care does. Whether it's public health, look at those numbers, mental health, human services, local aid, and biggest of all, education. That's the price we're paying for spending so much on medical care. And then these last, well, 2.5, I guess. This one just shows you how good we are in my agency. The percentages that our employees pay in premium, that's the yellow, and in out-of-pocket costs, that's the purple, they have stayed very, very stable. We have not transferred as many costs as a lot of my fellow employers have done. But why is it still awful? You want to do the next one? This is just 5 years. You can see it more clearly. It's sort of counterintuitive. People say, well, wait a minute, I'm getting more taken out of my paycheck every month, so how can you say what a good job you're doing? The answer is, of course, the size of the bar, i.e. the total expenditures. And last but not least, what are we trying to do? The triple aim. This is Don Berwick's paradigm that I'm rather fond of, primarily because it's so simple. It explains what the goals are. And those, in fact, are our goals. We should have better care as individuals. We should have better care of our population. Our statistics are terrible. And third, we should spend less per capita. So, the system you can turn it off because that's all there are. The system we have for addressing these cost issues is mired in the descendants of decisions that were made over the past 100 years. Decisions to adopt a fee-for-service payment system, to link insurance to one's job, to calculate rates by experience rather than by community, to drop health resource planning in favor of relying on the market, and finally, to exalt and worship the great God choice. What we really need now is the leadership to implement the best of many ideas that are already out there. We already know that fee-for-service is wasteful and sometimes even harmful. We already know that we've emphasized autonomy to the patients are left to fend for themselves to navigate between their so-called regular doctor, to specialists, to hospitals, to rehab facilities, to labs, to imaging providers, to SNFs, to hospices, without much guidance or help, even when they ask for it. We all know that we've paid specialists too much and primary care doctors too little in either money or, I think equally important, respect. We've tried, my agency has tried using claims data to evaluate the performance of specialists and tiering them, much to their distress, so much so that the Mass Medical Society sued to stop us. They forgot in their planning to sue us that we get, as a state agency represented by the Attorney General, who does not charge us. And they had to hire an expensive downtown Boston law firm. And you know how long the lawsuits take. They go on and on and on, and their meter was running and ours wasn't. So they threw in the towel after a while. I'm not supposed to take malicious pleasure in talking about that, but I do. Anyhow, we've promoted medical homes, and Rashika knows so much more about that than I do that I'm not going to go into that, and I'm sure he'll have lots to say about that. We've advocated for accountable care organizations to little or no avail. The take-up over the country and in the Commonwealth has been de minimis. We've established strict utilization measures to cope with the rising costs of drugs. We've helped to create a $6 billion wellness industry without any scientifically valid results. I'm not supposed to say that because everybody's supposed to be in favor of wellness, but it's true, right? Thank you. I've just had third-party endorsement there of that theory. Without any scientifically discernible results. Okay, we've required our plans to establish alternative limited networks at 20% lower premium costs, and we're now facing an orchestrated backlash from the excluded and obviously higher cost providers, mostly academic medical centers. I want to tell you a little bit about how we did our limited network project. We essentially channeled the behavioral economic theories of Thaler and Sunstein in their book called Nudge, in which they describe how to maximize the likelihood that people will choose an option that's good for them while still offering them choice if you do it right. Unless you're going to cut benefits or raise premiums or have very high deductibles, there are very few tools left to controlled costs. Limited networks, keeping the benefits absolutely the same as in the broad networks, enables purchasers and plans to negotiate prices with providers on somewhat better terms. You give us better prices and we'll give you more customers. It's not rocket science, it's common sense. And let me be even more clear. Providers who were excluded, almost always because they were very high cost and refused to accept lower rates, are already on the warpath to destroy this market-based approach using advocacy groups as their tools and the feel-good language of network adequacy to scare patients and regulate. Good God, already? Patients and regulators into setting up standards that will bring us right back into the chaos that resulted when every doctor and every hospital was in every plan and costs went through the roof. Let me remind you of some basic facts. Limited networks worked. HMOs worked. They were and are limited networks. Medicare Advantage works. It's a limited network. The Mass Connector actually requires works, and it's limited networks. And new state law actually requires that plans offer limited networks to the small group market. Ours work too, not just to lower prices, but to maintain quality as well. A recent study from the National Bureau of Economic Research found that our members who took advantage of our incentives to join our limited network plans lowered costs by 36% in both reduced use of high-cost services and prices paid. Primary care usage actually increased, specialist usage, ER usage, and hospital usage all declined. All of these results are exactly what most thoughtful people want to have happen. Greater use of primary care, less random use of high-cost specialists, ERs, and hospitals, except when appropriate. We began the program with 19,000 members in limited networks, and today we have 31,000. It's not a land rush, but it's growing. I would be less than honest if I did not acknowledge that there were some bumps early in the road. The meaning of the word limited seems to have eluded a few who signed up for this less expensive option, and some people were shocked to discover that they couldn't go wherever they wanted, whenever they wanted. Nevertheless, 1/3 of our active enrollees are in these smaller networks. They're paying less, we're paying less, and they're getting good medical care. We understand that we're fighting, or at least challenging, a dearly held American cultural value. The great God choice is a tough opponent, and we have a long way to go before people stop believing that more is better and most expensive best of all. We're very lucky in Massachusetts to have a high standard of medical care and a number of premier institutions that deliver really great care. But great care is delivered in many institutions, not just in the 2 or 3 most well-known. The only thing we have not done, and that I am personally opposed to doing, is to join the race to the bottom, otherwise known as adopting high deductible plans, encouraging people to be underinsured, in my opinion, or shifting more cost to our employees. Employers like these programs because they provide predictability as well as lowering their health care cost. They rationalize their decisions on the theory that putting employees at more risk is fair, since so many medical conditions are caused by people smoking and drinking and overeating and not exercising and indulging in all the things that are fun in life. Almost half of Massachusetts employers are currently using these programs. High deductible plans and their first cousins, private exchanges, shift the burden of health care inflation to the employee. And unless there are built-in escalator provisions as prices rise, but the employee's contributions do not, employees may gain greater choice of plans, but they will lose income. Most recently, having tried almost all of the cost-saving strategies I've been describing, we finally reluctantly accepted the reality that money talks. We decided that the time had come to push the implementation of Berwick's triple aim with a new contractually and fiscally based strategy. It has been said that vision without action is a daydream, while action without vision is a nightmare. We used our health plan procurement cycle to lay out our vision, a 5-year spending plan moving from +2 to -2 premium increases over the 5 years of the contract, coupled with a requirement that the plans plans pass on portions of their risks to their providers, along with specific improvements these providers were expected to make to lower costs, improve access, coordinate care, and put into practice the quality measures that they talk about in learned journals but not widely adopt. And the pushback has been substantial. You're moving too fast, although you might think that a quarter of a century is long enough to put a vision into action. They say, we agree with what you're trying to do, it's what we need to do, or even more frustrating, what we're really already doing, but don't ask us to sign a contract committing ourselves to doing it. These are the kinds of messages that we're getting from health plans and providers. Mind you, we're not giving up, but frankly, the steps that we're taking are small and the pace is excruciatingly slow. The move toward greater transparency is putting a spotlight on providers and is helping, but it is not enough to get the full attention of providers on the task of becoming the leaders of change rather than its resistors. A Harvard Medical School dean has been reputed to have said, of course doctors are in favor of progress, it's just change that they hate. What we're doing here is admittedly hard to do. Adding a new program is easy. Undoing plans and patterns of work, of compensation arrangements that have served many providers very well, of communicating across professional and non-professional lines is very hard to do. But surely, I'm on the last page, but surely doctors and hospitals must have noticed that their customers, not just us purchasers, but their patients are getting restless. They're going to mini clinics, they're going to Rushika's clinics, they're going to the internet, they're patronizing urgent care centers and imaging centers. Meanwhile, if you read this morning's Globe, you saw another example of how the software business is coming up with one app after another that means you never have to go see your doctor. You just click on. This purchaser believes that doctors and hospitals have to redesign what they do, how they do it, and how they get paid, if they don't want to risk having other people decide for them. Leadership is about making needed change rather than guaranteeing your constituents ongoing comfort levels. More dramatically, it may be said that it's about disappointing your constituents at a rate they can absorb. That's not a mandate that most leaders would admit is the best they can do. Nevertheless, it's the achievement that is needed, and we ought to keep pressuring them to get on with the job. Thank you.
Hi, good afternoon. It's a very hard act to follow. I was just doing the math. 29 years ago, I was an undergraduate sitting in this room taking organic chemistry. I think the PTSD is just wearing off right now. So I agree with everything Dolores said. I think the U.S. healthcare system, despite largely good people and good intentions, does not serve us well, right? I think the experience of getting care, if any of you have tried to get care, is just abysmal, would never be tolerated in other industries. I think our outcomes are just embarrassing. Two quick points. 30-day readmission rates from hospitals for Medicare is 21%. So 21% of the time we're discharging from a hospital, presumably thinking you're better, and you come back within 30 days. In any other industry, if your defect rate's that bad, all hell would break out. And I think, and the cost of care is just obscene, right? It's bankrupt from individuals. There's a direct trade-off between wages and benefits. And it's very clear. We've worked with unions in the past who have not been able to give people raises for 7 to 10 years because every penny of compensation that they've negotiated has gone to increased healthcare costs, while low-wage workers have not taken home any more money. That's just obscene, and it's going to bankrupt this country. All of the budget deficits for the next 50 years, all of them are Medicare and Medicaid, right? All the things that people argue about, whether it's the defense budget, Social Security, don't matter. So if we don't fix it, we're all in big trouble, right? And I think if you want to fix healthcare, as Dolores said, you've got to fix how we deliver care. If you want to fix education, you have to fix schools. If you want to fix healthcare, you can putz around the edges all you want, but you've got to fundamentally change how healthcare is delivered. And I think you need to have the courage to actually start over. Right? I think there are a lot of people talking about changing healthcare, but what they're doing is making small incremental tweaks on what we already have. And we've been doing that for a long time, and it doesn't work. And about 10 years ago, I'm a primary care doctor, and decided if we want to fix healthcare, instead of trying to go top down, hoping these big behemoth institutions will somehow fix themselves, want to go bottom up. And start with actually fixing primary care, where people can come and we can help them navigate the health system. And what if we decide to take a wholly different look? We have turned healthcare in this country into a series of transactions, documents, codes, bills, checklists, and all the things we do to try to fix it, whether they're medical homes or ACOs or whatever else you want to read about, are all more checklists and more transactions. And what if you said that the thing that heals people is not transactions but relationships? And you want to build a system about relationships and getting it right. What would it look like? And what if you decided you'd start over and just build a vision of what this ought to look like? What would that be? So we started a little company about 10 years ago here in Boston to try and do that. So what does the model look like, right? So it starts with changing the payment model. I think as Dolores said, fee for service. In general, we pay our doctors per doctor sick visit, and that's all we pay them for. What do we get? More sick visits. Stop the madness. I think it's the wrong way to pay for it. So we simply insist on getting paid a different way. Pay us a flat fee. Let us get on with taking care of patients. By the way, we spend about 4% of healthcare dollars on primary care in this country. 4%. That leaves 96% for what I'd call failure of primary care. Seems like a really dumb investment philosophy, right? So let's stop that madness and double down on the primary care. And let's take away the barriers, the co-pays and barriers to people coming to primary care. Why exactly are we putting a barrier to people coming to do primary care, right? Stop that madness. So fixed fee, double the amount of primary care, let us just get on with it. Then you are allowed to completely to change how you deliver the system. So again, our job is not to see one patient at a time, widgets off a line, which unfortunately is what it is in most systems, is that we have a population of people and they are our responsibility. Our job is to improve their health and keep them out of trouble, and do no matter what it takes. right? So when you believe that, all of a sudden, just think about it. The way we manage, let's call it something simple like diabetes in this country. Is you come to a doctor's office, they have 7 minutes to spend with you, usually wait about 2 hours before you see them. And then, I see you and I say, with 7 minutes, I can basically tell you, you should eat less, you should exercise more, take your medicines, good luck, sucker, I'll see you in 3 months, right? That's not that helpful. So what should it be? So we build a very robust team around people. Of course, there are doctors, because what we're trained to do is diagnose and treat. But the hard part isn't that. The hard part is how do you, as a patient, actually execute on it? How do you actually change your life in order to do that? So we have folks we call health coaches. And they're people from the community, speak the language of the people they serve. And we have 4 of them per doctor, so they can have small panel sizes. And they can work with people on making a plan, knowing what exactly to do. If that means going to the grocery store with you to show you what you should be buying, it means going for a walk with you, taking you to the gym to show you how to do an exercise, holding your hand when that's the right thing to do, kicking you a little in the behind when that's the right thing to do when you're not doing well, right? That's what they do. And we pick them for one thing only, which is empathy, because that's the one thing I can't teach, and I can teach everything else, right? And these are great jobs, by the way. And we have social workers in every practice to help people with mental health and social barriers that keep them from doing things. So we start each day off with a huddle where the whole team gets together for 45 minutes, and talks about our patients. And we don't talk about the people coming in because they're coming in, we'll figure it out. We actually talk about the people who are not coming in, who we're worried about, and who we ought to be reaching out to make sure that they're okay. Right? And how do we do that? Is we get data about them from all over the place. Are they filling their meds? Have they been in the hospital? Are their labs out of date? And it triggers us to know who to reach out to. We see people one-on-one, but we do things by email and video chat. We have groups get together. And we don't call them groups, by the way, because no one wants to be in a group. We don't call them classes, because you don't want to be in a class, but we call them clubs. Everyone wants to be in a club, right? So we have diabetes clubs, and we have Zumba clubs, and we have walking clubs, and we have aging well clubs, and people get together. And you start it because you think it's an efficient way for you, the doctor, to teach people. And you realize actually the value is in people teaching each other and supporting each other, because they have to live with the disease and help each other more than I can ever do. We also build what we call a de facto narrow network, a little what Dolores is doing, of a small group of good guys who are willing to work with us and manage people better and co-manage with us. And again, when Dolores tries to do it, there are lawsuits that are being filed, and there are people marching in the streets. The great news is when I do it, no one knows it's happening, right? And they can't fight against a ghost. And we use all the data we can, and we simply do it. This works really well. We're doing this about a dozen times around the country. We mainly what we have worked with is our union trusts and with self-insured employers who are progressive to build these practices for their employees and their dependents and allow them to come as a choice. What we've seen is our patient satisfaction rates are off the charts. Of course, people love it. Our outcomes are much better. So an example, we have a practice at Dartmouth University for Dartmouth College employees. And when people come into the practice with hypertension, only 55% of them are under control. Again, that's embarrassing, but that's the national average. Only about 55% of people with hypertension are well controlled. We get that number up to 90%, and we do similar for diabetes, et cetera. And then if you look at the downstream spending, we can drop hospitalizations by 40%. We drop ER visits in half. We drop unnecessary specialist visits tremendously. We drop those 30-day readmission rates from 21% to 12%, within a year. And it works. Of course it works, right? Help people manage their health better, give them the right tools and resources, and you lower healthcare spend. But again, the key is the lowering healthcare spend is not the thing we're trying to do. Right? Our job is help people improve their life and improve their health, and the side effect is they will lower healthcare spending. Right? It's really important to get that right. So again, I think the problem is we've been accused of a lot of things, by the way. This has not always been popular, as you can imagine. We've been accused of raising expectations, of making other practices look bad, we might be upsetting the status quo. Was actually another accusation. And the point is exactly what we're trying to do, right? What we're trying to do is demonstrate a vision of what this ought to be. Our mission is to transform healthcare, and the way we're going to do it is not by talking about it, not by writing about it, no offense, Meredith, but we're friends. But what we're going to do is actually just do it better and convince patients to vote with their feet, and that will not only give the people who come to us a better experience and better care, but will actually, to be honest, kick the other people in the behind to try and change. And they'll close with a story. People ask, well, all the things you do, what is it that really makes a difference? And we had a patient I still remember well. Her name was Joyce, and we were seeing her in a practice we ran in Atlantic City, New Jersey, for the Casino Workers Union. And she came in, and she was what the health coach described as a hot mess. Her hair was disheveled, her diabetes was out of control, her blood pressure was out of control, she wasn't taking her medicines, was in and out of the ER, in and out of work. And so I met with her and sort of get her with the program, hooked her up with this great health coach, our best one, Millie. And I had to leave that practice, and about 6 months later I came back to visit, and Neil Patel, one of the docs, said, you remember that lady we met the first day, Joyce, who we said was such a hot mess? I was like, yeah, well, she's back, I want you to meet her. So he takes me into the room, and I almost didn't recognize her. She looked amazing. Hair was combed, a little bit of makeup on, looked at her chart, diabetes under control, blood pressure under control, back to work, taking her meds. And I said, Joyce, you look amazing. And she said, thank you, I've never felt better in my life. So I said, well, will you help me, Joyce? Like, what is it that we've done to help you get so much better? And she didn't say, you were a great doctor. She didn't say, any of the other things we do, which is a different business model and a different IT system. She said, well, actually, Doc, it's really simple. Is this health coach cared about me. She taught me to care about myself, and I didn't want to let either of us down, right? This health coach cared about me. She taught me to care about myself, and I didn't want to let either of us down. And it's really that simple, right? If we can get the relationships right, if we can rebuild our health system, get rid of all the crap that we've layered onto it, and rebuild it based on relationships between doctor and health coach and patient, us and the specialist, us and the payer, I think we can fix healthcare, and we can, in a lasting and the right way, get healthcare costs down. So thank you.
Okay, coming up third on the panel. And now Rashika and I are old friends, so I didn't take that too personally. But I think I see the small role, and thank you to Bill and Daneen for organizing this, and I see the clarity of their vision and why they put me third. So what I hope I can help you with is a little bit of navigating where all this fits in. So both Dolores and Rashika, to me, they have come here to tell us that there are good ideas out there that are feasible and that really work. But they're not easy, and they really take leadership. Both of them talked about pushback in doing what at some level seems so common sense, and common sense, unfortunately, perhaps is not equally endowed. So I'm going to bring us back to what I think is my assignment to discuss where there might be some traction for an employer like Harvard University around improving the value of our health benefits, and doing so in a way that is equitable and really thoughtful. I am that pointy-headed academic. I apologize for that. But as an economist, as I start looking at this, I have to say first and foremost that, and no one knows this like the union, that the cost of your health benefits and your cash wages, it's a zero-sum game, right? So $1 of savings in one is $1 in the other. There's a little friction, but in general, that's the way it plays out, and that's why I think some of those Taft-Hartley funds who have worked with Rashika before, it's crystal clear to them that if they can get their hands around this, they can get their wage increases. And so that's always in the back of my mind. And that means that there is this area of opportunity that employers have no interest in depriving their employees of the benefits of their healthcare spending. So to waste money on health benefits, to spend their health benefit dollars poorly, is not in the interest of employers, and clearly it's not in the interest of employees. So that means that there should be some common ground. And particularly if you're concerned about equity and low-wage workers, as Rashika referred to, we really are in a crisis in terms of that lovely chart that Dolores showed. I love that chart. You can do a household budget that looks like that too. Over the last couple of decades, all of your income, all of our incomes have gone into healthcare. And that means we're spending less on everything else at the household level, not just at the state government or federal government level. And at the bottom of it, the healthcare spending trend, the health benefit spending trend is all about healthcare. There is some contribution to the trend on the part of the structure of the insurance market and insurers, but really what's driving healthcare spending to these unaffordable levels is healthcare. And so we do need to really think about how do we change the way people get their healthcare, what we pay for the same service. So there's both the sort of what kinds of services people get and how they get them, but also the prices. And I think it should be clear also that every good idea is going to have some downsides. So we can't sort of say, oh, well, you know, someone pointed out that your quality measures aren't perfect. That's true. But every good idea has some downsides. It doesn't mean it's not better than the status quo. And so the challenge is then we really have to understand what are the costs and benefits locally for each of these kinds of ideas so that we can make it fully informed trade-offs. And again, I think one of the things that gets swept over a lot of times is high deductible plans save money. Yes, but out of whose pocket and for whom? So we need to really understand the distributional effects, and it's complicated. So I said before that employers have the same interest in reducing health benefits. It's true in all of our work, when these high deductible plans are introduced in ways that seem to save money, they could potentially increase wages, but they're not, those savings are not equally distributed. If you're a person with high healthcare needs and you have a high deductible plan, you've just had a pay cut. And so the within employee distribution of that impact is going to be really important too. So as I hope we'll move to the discussion very, very soon. I think we could talk about two categories of initiatives. One is on the side of directly working with healthcare delivery, and the other is on the side of working through employees to help them make better selections of provider, of treatment choices, give them price information, for example, work through the patient and the consumer as opposed to working through the delivery system. And frankly, even though Harvard seems like an enormous institution, it is small as a purchaser goes in the healthcare delivery system. It's hard for Harvard to make the changes that we need to really fundamentally get the attention of the large healthcare systems, including the ones with which we are affiliated. So I believe in terms of health policy, we really need to work on the delivery system side. As an employer, nothing I have seen suggests to me that that kind of initiative for an employer the size of Harvard will be very effective on its own. Coalitions of employers have been more effective in these areas, but I think, relatively speaking, we should focus on what we can do in terms of where employees seek care, how we empower them to make informed choices. And I was going to mention wellness too before I told you that the evidence is not good. So on the delivery system side, I do think that there may be some opportunities with something like a special care center, as Rashika described. The evidence that we have about targeting very tailored, coordinated, much more proactive care suggests that for very high-risk populations there can be savings, and that is an initiative worth considering. The question is a little bit about how would that fit in locally here, and what population is the right target population where people who could really benefit for those initiatives. There are fixed investments that are required, and so we can talk about whether that's a good idea. The union, I think, has already pointed out that we have what I think of still as health services, you'll forgive me, HUPE. We do have our own mini delivery system here that perhaps could be leveraged to play a bigger role as a part of the delivery system that Harvard can, in fact, do a lot more with than the rest of the delivery system. So then on the employee side, the choices have all been tried before. The evidence is fairly clear. So I can tell you we could raise copayments and deductibles, and we know that does cut costs. And I think Dolores said that's why employers do it. It's quite predictable. If you throw a $1,000 deductible into a health plan, that the total spending will be less. The employee's share will go up. The evidence also suggests that what people choose, what they forego when they face those deductibles is not necessarily low-value care. So that's not great. The distributional consequences, need I say, are also not great when it comes to high deductibles. And so most health economists do not view this as a way to improve the value of healthcare spending. It's a way to cut the costs, and it has serious distributional concerns. There are other ways of working with benefit design at the product level or the service level. So we could, for example, raise copays for emergency department visits for certain things that could have been seen in an urgent care center. You can think about this most easily, I think, for pharmaceuticals, where we make very low copayments for generic drugs, very high copayments for brand name drugs. These strategies are feasible. They save a little bit of money, but they tend to be relatively narrowly targeted. This is value-based benefit design. I think there's a complexity issue in thinking about whether we can scale that up. But maybe there are opportunities. A related intervention is known as reference pricing, which I know really sounds geeky, but the idea is to say, well, you know, you can get a knee replacement at Hospital A that we know has good outcomes, and the total cost of that knee replacement is half the knee replacement at Hospital B. And this, you may have read about, has been implemented in CalPERS. And patients who go to Hospital A will have their knee replacement paid in full. Two alternatives. Hospital B, the patient has to pay the difference if they want to go to Hospital B. So that, again, we have to ask ourselves, is it sufficient that patients have the choice of Hospital A? Can they get access there? Then maybe it's okay. And if people really want to go to the high-cost hospital that doesn't have better outcomes, then they can pay out of pocket. Or, depending on the ability of the payer generally to negotiate, the payer simply says, we're only paying $25,000 for that knee replacement, and you cannot bill the patient more. So there are a couple of different ways to do that, but if there are high-cost services where there's a lot of variability in what it costs, and there's a pause point, these are elective, so people can say, okay, I understand my benefit design, and I understand that if I go to the low-cost hospital, I will pay less or nothing versus the high-cost hospital. So that may also be an initiative that is worth considering, and there is some emerging evidence about that. I think the question again is there anything that Harvard employees use at such a high rate that if we picked a few of those things, we could generate real cost savings? And then to go to the tiered and narrow networks, Dolores talked about narrow networks, but I think just because she only had 15 plus her few extra moments. She didn't talk about all the things they've done. The tiered networks that we had the pleasure of evaluating were also very successful, and also with one of the unions that has worked with Rashika, we did another evaluation. It's very clear that if you give people the choice to stay in a narrower network and pay less versus go out, they're going to stay in at the margin. And I think more importantly, what we found is that patients who had established relationships with providers who were not in the best tier, they stayed with those providers. So people were clearly making value-based choices for themselves that suggested that they weren't just being forced into the better tiered networks. So we do have good evidence on narrow and tiered networks to suggest they can be cost-saving and to suggest that enrollees can begin to understand them. The more complicated we make benefit design, the more we should be concerned, again, about education and engagement of people with these health plans at the point of selection and at the point of care. Those are challenges for sure. As I mentioned, there is no free lunch here. So just to back up then, I think For one, we do have quite a bit of evidence on all of these demand-side initiatives, and ultimately, we have to consider our values. Do we want to make sure that the way we control costs protects the least well-off, either in terms of health status or in terms of ability to pay? And then that evidence is not enough. We need to bring our values to the table as well, and then also consider the local environment. While these things have been proven in Las Vegas, I can tell you Las Vegas is not Boston, and on the healthcare side, probably it's a good thing. But also, it is likely, and this is one of the things I liked about the union's 7 things that we can do, is that it's likely we're going to have to do a lot of these things. Dolores has been doing all of these things over the years, and they have all been incrementally successful. There is no magic bullet, one-off. There's no solution out there that we're all ignoring. It's a whole lot of small changes, but also changes that are locally appropriate and appropriate to our values in health benefits and everything else. Thank you.
So we're going to have about a half hour, 35 minutes for some questions. There are going to be helpers in the aisles who have microphones and who have cards. And if you'd rather write a question down and send it up here, it's okay to ask anything of our panelists and of Dunning and me. And I think maybe I'll try to kick things off with a little bit of a question. I think all of our panelists talked about the trade-offs between choice and cost and between choice and coordination. I sometimes feel like, I feel like my attitude as a consumer of healthcare, as a patient, and a participant in Harvard's plans as a Harvard employee, I feel like my attitude toward it has changed over the years. I think when healthcare cost less 15 or 20 years ago, I might have said, money's no object. I got to have the choices. I don't want to be told at a critical moment in my medical life that my choices are narrowed, or that I can't go wherever I want, whenever I want, as Dolores said. But then it turned out for me, and I'm wondering if it turned out for a lot of people, that there was a threshold, that there was a point where money was an object. Do you see in your work, all of you, that attitudes about choice in the patient community and in the employer community have changed in the past 5 years or so? Have we reached a point where unlimited network, broad network care is so expensive, is so much more expensive, that we see that there's been a tipping point, or that attitudes are turning back the other way?
A little bit, I would say, has changed. I think people who are pressed for, how to get through the week and pay their bills are looking at some of our less expensive plans and choosing them. I will tell you that what we did was bribe people in our limited network rollout. We did, I thought this is pure Sunstein-Thaler. First of all, we said your healthcare coverage ends on June 30th. You have to choose a new plan or re-enroll in the same plan. The theory being, we know that less than 2% of all of our enrollees switch plans every year, unless something monumental happens. So this was to sort of force them to at least stop and think about what their options were. And when we did that, and we also said, and if you choose a limited network plan, we will waive your first 3 months of premium. That, adding a little bit of honey, made the medicine go down a lot more smoothly. Now, we're not going to do it every year. We can't do it every year. You lose those copays or those premiums, but which are, they're only 17%, but 17% is a lot of money. Anyhow, and once people got into them, some of them decided, yeah, hey, this isn't bad. I can be comfortable here. But having said that, I would say that 100 years of branding and massive advertising. Do not forget that a lot of what people think they want because they have heard it over and over and over again. My favorite being I shall not mention their name, but you all probably know who I'm talking about, radiology or imaging company advertised a couple of years ago at Christmas time, the present for the man who has everything, a full body scan. He may have some disease lurking there for which he does not yet have symptoms. And it was only after massive complaints that they pulled that ad. But people hear it all the time. We did not used to have advertising of medical facilities. It was considered unprofessional. But it is what it is, and unless we prohibit it, as they do in some countries, I think it's a hard push. Little by little, yeah, but not massive switching, no.
I wonder, Bill, if the price transparency efforts in Massachusetts will change some of the conversation when people begin to understand. I think what's been really hard about the choice story is that a lot of it is obscured behind your employer, and so there is a natural suspicion, well, you're just cutting my choice and keeping my pay increases. And the more people see about where the cost is coming from, I think the more we'll fight back. But I think going back to something Dolores said too, I think we need leadership at the government level, state government in particular, that just steps in and makes more of this obligatory. Otherwise, it's really hard. It's really hard to fight the parts of the delivery system that already have power.
Just a PS, if I can. We need leadership from government, and we need leadership from the medical community, and we need leadership from the health plans, who have not been exactly aggressive in this regard. Unicare, which is our indemnity plan, and everybody says, oh, the indemnity plans are the most expensive and the least well-managed and all the rest. They have just sent out a flyer to every member of their panel, which says, a picture of a woman who says, oh, my surgery went well and I didn't have to pay a penny. And then you turn it over and it says, guess again, your bill was paid for by your insurance company. Your insurance company is going to add it to their experience for the year. Next year, your insurance company is going to raise your rates. Don't kid yourself. It was not free. And but that's unheard of for a health plan to actually do a piece like that, and we need more of it.
Should we take some questions from the audience? Is there a hand or someone to pass the cards? Go ahead.
Dolores, you mentioned Don Berwick's 3 aims. Triple aim. He also promotes single payer in the United States. How does that, for the 3 of you, fit in with your visions for healthcare delivery in the United States and basically medical care delivery in the United States?
If I thought there was a snowball's chance in hell of its getting through the United States Congress, never mind the current Congress, but can you imagine with the next Congress? So we have, yeah, I mean, of course, I'm a tax and spend Democrat. I think, well, and that's part of the problem. I mean, part of the problem is that all of the employers have drunk the anti-tax Kool-Aid. So they all, there are options. You could have gone the other way, but we chose not to. And as I say, untangling that I just can't see it happening. So I work with what we've got.
So regardless of what you think about single payer, the key is, I think, fixing the delivery system. And in some ways, even if we go down the single payer route, we'd be careful to make sure that that payer enables delivery system innovation. So Medicare is de facto a single payer, right, for about a good chunk of the population, 40%? Something like that.
Dollars.
So good, right? So about 40% of the dollars is spent by Medicare, so it's a de facto single payer. Before recently, to get something changed in Medicare required literally an act of Congress, to sort of the most calcified. And it's why we started innovating with self-insured employers and union trusts, because they don't have to follow these sort of political rules, right? So again, even if we go down a single payer route, we need to make sure that we structure that single payer in a way that they can actually innovate the model.
Yeah, I was just going to say also that Canada is a good example of, they have a single-payer system. They have the same dysfunctional delivery system that we have with fee-for-service medicine. Go ahead.
Let's do one off a card here that somebody sent in. So I'm going to read this question, and then I'm going to add something to it. My question. Can you speak to the plausibility and effectiveness of implementing wellness programs in firms, in workplaces? This could include meditation, yoga, dedicating an hour a day for employees to exercise, et cetera. So you've all said the usual not optimistic things and unimpressed with the findings with research findings on the subject. So so that's a good question, and I'm just going to add to it. Why do you think that the research results are so unimpressive? Because it's so intuitively appealing to so many people in this room, a lot of whom I know, and in the conversation that happens within our union, in our meetings, and in our thinking about healthcare. There's so much enthusiasm about the idea that that modest investments in programs that can happen in the workplace seem like they ought to be able to make a real difference in terms of employee health, not just in terms of behavioral management and these kind of programs, but also in terms of disease management programs that could be based in the workplace. If the kind of efforts that have been undertaken aren't producing impressive results, is there a reason for that? Is wellness not a workable idea, or are we doing it wrong?
Well, so I would say, first of all, the research is extremely underwhelming, and most of it has been done by people with an interest in the outcome. So it just raises a lot of issues. But I think also, if the question is, do these programs save money versus improve well-being, I think we need to distinguish. There may be reasons why we want wellness programs for wellness, as opposed to saving money on health benefits. Those are two distinct goals. I think the reason that well-designed evaluations of wellness programs have turned up such modest results is that we have an enormous self-selection problem, is that people who are already motivated to do the kinds of things that wellness programs deliver are the ones who sign up. And so the incremental benefit for those folks is modest, whereas if we could only get the people who don't come. And so there may be, I would say it's a reasonable thing to challenge the idea that it can't work, or that it can't work here, if we had the right programs and use what we know about behavioral economics to get the not so usual suspects to sign up. It is not impossible that you could get different results. But I think mostly it's because, you know, we have an exercise program that basically gets people who are going to go to the gym anyhow. And so I think that's the challenge there, is figuring out how to reach the people who can most benefit from it. And then it may or may not be that you have cost savings, but you may still have benefit in the sense of wellness.
So I agree with Meredith. I think this is a complicated thing. So first of all, it is absolutely the right thing to do, right? So the point of the healthcare system isn't to save money. The point of the healthcare system is to make us healthy. And clearly meditation and a number of these wellness things help improve people's health. I don't think there's any question about that. I think it's clear that if you want to do it for an economic return, you need to aim it at the people for whom it can actually benefit, right? So if you aim it at healthy 23-year-olds already running marathons, of course you're not going to see a difference. If you do like what we do, is take multiply chronically ill folks who've never set foot in a yoga class and start teaching them yoga, you actually see a benefit, right? So you need to target it. Number 3 is, I think there are benefits to these things that go way beyond medical costs, and some of it's self-efficacy, some of it is we're seeing just sort of outlook on life and absenteeism and disability, and there are lots of other benefits. And finally, I think this is a big bugaboo, is that what's the time frame we're looking at? Almost all of the studies that have looked at the impact of wellness are looking at 6-12-month impacts. Of course it's not going to make an impact in 6 or 12 months, right? This is a 5-year game.
Although that raises another question from the point of view, if you're trying to engage your employer to invest in these, the turnover is much less than 5 years.
Right, but so I do think that one of the problems we struggle with all the time is we're trying to improve healthcare quality by fixing people's health. That sometimes, why do we think that'll happen in a year? Of course, it won't happen in a year, right? It's taken years and years to get to where we are. So I think we as a society need to be willing to make those investments and be able to look out further than 1 year. And I think 3 to 5 years is the right time frame.
Yeah, I want to add to what's been said, which I basically agree with. I do think it works better in smaller, concentrated companies. Trying to do it in something as big as the state government, when workers are spread from here to the Berkshires, is very hard to do, and it's mostly done electronically. It's not really hands-on. And it's self-selected, as you say. So that's why I'm so sort of uncomfortable about it. But the reason I showed that slide, remember, of the impact on the state budget of all the medical expenditures, was not just that other state functions are being affected, but the nature of those functions. I mean, kids don't go out to play. Their mothers make them stay in the house watching TV and becoming couch potatoes because there isn't a supervised playground nearby. And they're afraid, that they won't be safe if they go outside. That's why public recreation is important. Transportation. You think, what's that got to do with health? Well, I mean, all you have to do is look at countries around the world where people use subways, and they use subways. Guess what? They don't stop at your front door. You have to walk 2 whole blocks to the local tube station. Whereas, we just fall out the side door into the car and then out of the garage and under a building and never move them up and sit all day long, especially me. I'm the boss, so people come to me. I don't even have to walk down the hall to talk to somebody. Those things, and most important of all, the single highest correlation between health and something else is education. And we're starving education. So it seems to me that all of those things are just as important as to whether or not you take a health assessment, in which I lie. I mean, I never tell them. I don't know about the rest of you. I'm not telling anybody how much I drink. They never catch me. So I just think all those other things are significantly more important to a healthy population.
Amen. This is a question for Ruchika. Do most of the patients at IORA practices have the choice to use traditional practices as well? Is there any indication that improved outcomes at IORA practices could be the result of motivated people self-selecting into the practice?
Yeah, I think it's a great question, and a question we ask people like Meredith all the time to help us answer.
Who's the health economist on there?
So it is a choice, right? We never want to force people into coming to our practice. So let's use Dartmouth College as an example. The university offers it as a choice for people. By the way, about 1/3 of the Dartmouth College employees and their spouses have chosen to leave their current doctor and come to us. By the way, that's made a huge impact on their current doctors. That sort of made them sort of...
In Hanover, New Hampshire.
Yeah, in Hanover, New Hampshire, and pay attention, right? Because it's a small community they have. But in any case, it's a choice. So you worry about it when you look at the trend of what's happening to our patients relative to what, and is it selection bias? So the best way to answer that question would be to randomize people. To force them, yes or no, flip a coin if they decide to join the practice. We have not found any sponsor who's willing to do that. And I think it's just logistically very hard. The best other way to do it is a thing called a case control study and using a thing called propensity matching, where what you do is you take the people who come to the practice and you try and match them to someone who's not in the practice, who looks the most like them, and follow the two across. Now, Meredith can talk a lot about how you match those, and that's it seems more like an art as well as a science. And so we try to do that as much as possible, but it's hard.
Yeah, absolutely. And I think, I think at the end of the day, in advocating for a position one way or another with the union and Harvard, we'll need some level of evidence, but we're not everybody's willing to set up a randomized controlled trial, and I don't think we should expect that level of evidence. It's trying to get the best information we can, because we know the status quo is toxic. So, and we don't, it's not like we did a randomized control trial to get here. So, so let's not make it impossible to move ahead.
Can I add a PS on the wellness thing? I should have said, I think Americans work too hard. I mean, did you see yesterday's Globe? Yesterday's Globe had an article, I think it was yesterday's Globe, about vacations and who takes them and how long they do in this country rather than other countries. A, our vacation allotments are smaller, and B, people get, and I'm as guilty as anybody, don't take all their vacation days that they are entitled to. So what about stress as being related to wellness? And people are scared to death of the security of their jobs. Somebody else gets laid off, that doesn't make them feel, "Phew, I escaped that bullet." They feel A, guilty that their friend or the person who sat next to them is gone, and B, guess what? They inherit that person's job. Did they get a pay raise for it? No, they did not. So I just think there is a culture in which you're supposed to, just bust your butt and be thankful you have a job. And when they talk about doing exercise, an hour a day or 3 days a week, excuse me, people have lives. They have kids who have to be taken to soccer practice or the dentist or whatever. It's very hard in our society to craft the time, never mind those of us who hate doing it, but but if you in fact have other obligations in life, it's very hard to carve out the time to do it. So I think we need a cultural change on a lot of lines.
Thank you. Let's take another question from the audience. Anne?
Well, that's a perfect foundation for what I was about to ask, because my question was your reaction to where the efforts at health promotion and wellness should be cited. We've had an excellent presentation by Dr. Fernando Pol about how things work in a medical practice. We've had wonderful explanations about other influences on health, from agricultural policy to transportation to education to income. And yet, we're looking at employer wellness plans. Why would anyone think of citing health promotion in an employer insurance policy? It's an interesting oddity, perhaps because employers can't directly affect so many of the other costs that are raising the price. But as one who has expressed some skepticism about these programs being used in insurance, I worry a bit because employers might drop programs that don't provide a decent return on investment. Why would you keep it if it didn't produce some kind of profit for you? Second, if employers are truly worried about the health status of employees, does that mean that an employee's health status now becomes a condition of employment? Most of employees in this country are not in a collective bargaining unit, and they can be dropped for no reason. And to the extent that we make health the ultimate goal of employment, I worry that this will jeopardize many, many people, mostly the most disadvantaged, whose conditions are targeted by these programs. So where should we put them?
Just an uber point is that the linking health and healthcare and employment doesn't really make sense, right? It's a historical accident that we are sort of almost alone among industrial companies to have. And you think about the big picture, back to single payer point, the best argument for single payer or anything but employment-sponsored insurance is you work 25 years in a job and you pay in a huge amount of your wages into the insurance system, and you get sick enough to lose your job, you lose your coverage at the very point you need it. That just makes absolutely no sense at all, right? And so I think this wellness thing is just a part of that, is why do we link it to employment? It's sort of because of historical accident at the moment. And I think there are some who believe that these exchanges that are going on might be one way out, as some employers choose to sort of unravel their not the big ones like Dolores, but the little ones. Say, why am I buying insurance? I'll give some money, buy on the exchange. The problem, of course, is most of the plans on the exchange are pretty crappy, right? There are these bronze plans with a $6,250 deductible. So you're almost de facto uninsured for the first $6,000, and I think so I'm not sure how that's going to play as it plays out.
Well, for sure, the reason employers offer wellness programs and health benefits and pension benefits is only to win the labor market game. So they want to attract employees and attract the employees that will help them, in this case, accomplish their mission, or for a profit company, make the most money. And so to the extent that those wellness programs either do make it possible to deliver compensation in a way that's valued more by employees overall, that's good. But I do think there's a little bit, and I'm not questioning any particular employer, but there is a little bit of, if I offer programs that attract young, healthy types, I might get more young, healthy types. If I have the world's best, cancer support group program as an employer, seriously, there are concerns that one might have about the incentives for employers to offer programs that are strictly about doing well for the current population versus trying to attract a workforce that net may be better for the bottom line.
I think there are two reasons in addition to that. One is that nobody else is doing it. You remember what was Jocelyn, the Surgeon General of the United States?
Jocelyn Elders.
Yeah, Jocelyn Elders got fired because she had the temerity to have an aggressive anti-smoking, or was that Coop? That was Coop, Everett Coop, yeah. An aggressive anti-smoking campaign, and that didn't sit well. Oh, and she also, I think, supported the distribution of condoms. Yeah, that got her in trouble. So, again, you take the money away from the people who appropriately should do it, public health being the absolute most appropriate example, and somebody has to do it. But I think there's another reason. This is uncharitable of me, but I think it's because employers really don't want to face up to doing some of the harder things that need to be done. It's a kind of a rescue fantasy. So you say, I'm doing something about healthcare, we're going to have wellness, and my people will get healthy and they won't be absent and they won't go to the doctor and I'll save money. And I just think that's just delusionary. They don't want to just say no to an expensive provider, and they don't want to offend their employees by dropping a plan that they like because it's easy and they never say no. And I just think it's that nobody wants to face the real problem, which is we spend too much money, and some people are getting rich who do procedures. And those guys have gotten their grasp on where the dollars are. And the poor, well, I don't know if you're poor, but anyhow, the poor, the poor primary care doctor or the pediatrician, even the psychiatrists don't make money anymore. But the dermatologists and the orthopedic surgeons and we have a office building across the street from our office building, which we refer to as the eye and skin factory. And those people pull down $1 million a year. I did a little arithmetic. They do. There's something wrong with that picture, and employers don't want to be part of the solution if it means sticking their necks out.
So
Yeah, except for me, and I've got tenure.
I'm not really supposed to pretend to be an expert and try to help answer a question, but I can't resist a couple of thoughts about that really important question about where to cite, where's the most appropriate place to cite wellness programs. I think another argument that might be made for the important role that employers can play is if we can succeed in improving health outcomes and health status even a little bit, there are other benefits for the employer. So there are other reasons for an employer to invest in wellness, in effective wellness and disease management programming, besides, for example, a reduced use of sick leave, medical leave, and
we
and
do
sick
sort
days.
of all hang around together all the time. So
We do, yeah.
there is that co-location.
And more of us hang around together more all the time. So
Try taking the Fritos out of the vending machine.
Oh, come to the School of Public Health. We have all natural vending machines.
I also think it's interesting to think about the idea that employers who engage in projects with Rushika's firm, with Iora Health, are actually paying a bit more for primary care than they would otherwise, and there's a lot of wellness programming happening in Iora clinics. So that redesign of the primary care delivery model is also to some extent a wellness investment, I think, and by some of their results a very effective one. Dolores mentioned specialists, and there's an excellent question here, came in on a card that might be a good one to go to. Does the lack of communication between specialists and primary care docs have a dollar cost that can be quantified, or an impact on health quality that can be quantified?
That's yours.
I can tell you a story if that helps. So it is a huge problem, right? Unfortunately, in much of the country, the model of care is that you go and get your hypertension treated by the cardiologist, and your asthma treated by the pulmonologist, and your reflux treated by the GI doctor, and they never talk to each other. And there's a huge cost to that. So one of my favorite stories, we had a patient in a Las Vegas practice who came in one day, and I was seeing her, and she'd been hospitalized for 6 syncopal episodes, fainting episodes in the past year. And we asked people to bring all their medications in. So this is a little old lady from Guatemala. She worked in the Bacchanal buffet at Caesar's Palace, making salads, and 68 years old, and her daughter brought her in, and so she has 27 medications that she's taking in these 2 shopping bags. And we line them up, and they're prescribed by 11 different doctors, because we read the names on the labels. And these 11 doctors clearly don't talk to each other, because there are 7 different antihypertensive medicines, 3 of which are the same ones, 3 lisinoprils, 10, 20, and 40 milligrams. So I look at the daughter, and I'm like, do you give her all this medicine? And she said, well, doctor, can I admit something to you? I thought it was too much medicine. I was like, you're right, this would kill a horse if you give them this much medicine. I said, so what did you do? And this is, again, a not very educated lady from Guatemala. Said, I did the only thing I could every day, doctor. Every day I say the sign of the cross, and I pray to God, and I reach into the bag, and I pick out 5 medicines, and I give them to Mom. So on a day when she/God has a good day, and Mom gets 1 hypertensive, 1 diabetes drug, Mom does great. But on a day when she/God has a bad day, and they pick 5 antihypertensives out, Mom's blood pressure drops to 0, boom, she goes down, and she gets taken to the hospital, right? And so unfortunately, there's way too much of that going on, the sort of lack of coordination. And part of the problem is, again, we seem to be willing in this current payment model to pay for all this stuff that people do, but not for coordinating the care and making sure people actually get this taken care of. So, again, what's the cost of it? I would bet it's 10 or 20% of healthcare costs are based on sort of poor coordination.
I mean, their computers don't talk to each other, and they refuse to accept the x-rays from somebody else or the tests from somebody else. They insist on doing them all over again. Now, the fact that those are profit centers is maybe influential to some degree, but, I mean, those things cost money. And by the way, I do not have tenure. I made that up.
Something comparable, Dolores.
We're coming near to the end of our time. We could take one more question from out there if somebody's got a hand they want to throw up and to the microphone. Or if there's not, oh, yeah.
I'm from the Share Union, which is HUCTW's sister union, and we represent employees at UMass Medical Center, a high-cost academic medical center that's getting tiered out. And so our members are, what was your expression? Every good thing has some bad sides? And our members do high expensive tests that, everybody's saying they don't need, and so we are laying off radiology techs and that kind of job. And so I totally get that we need to change the delivery of care, but there's an equal pressure to just have cheaper people provide the care that's acting on our hospitals and other hospitals, and that's not a good pressure, because if you contract out a function to a low-paid, low-benefited person, they're not going to deliver better care. They're not connected to the patient in the same way. And so is there any way to help hospitals figure out how to redesign their care without putting the pressure on just cutting the wages?
That is a really hard question.
Meredith has to play the role of a hospital expert now.
I think I am not smart enough to know the answer to that question, but it does, it does really bring us back to this. We have this market system, for better or for worse. We've decided that we're not going to have government intervene in the way care is delivered at that level. There are obviously a lot of regulations. And so instead, we have these very high-level incentives, and then every hospital has to figure out how they're going to go about responding to those incentives. I don't know, given how difficult it is also to develop regulation without unintended consequences of a different kind, whether that's the right kind of fine-tuning. I would say that that the hospital should engage the hospital staff in efforts to reduce waste. There are a million ways to do that, and I'm not at all an expert in this, but I know hospitals have used lean technologies, other kinds of initiatives, and there is always a wrong way to go about cutting costs, but we would aspire, of course, that our healthcare partners look for the right way, and I wish you the best.
I would add to that, there is a school of thought which says, if you give, and this is specifically directed toward hospitals, if you give hospitals more money, they will spend it. If you give them less money, they will figure out how to do it for less money. And what I think hospitals need to do is to rethink what role they are going to play in society over the next decade. What's happening out there with mini clinics and all the rest should be a shot across the bow. It should be a message loud and clear that the customer, the patients, I'm not talking about the purchaser, is not happy with the service that you are offering. They don't want to go and sit in an emergency room for 3 hours. They don't want not to be able to see their doctor or to call after 4 o'clock in the afternoon and not get an automated message which says if you're having an emergency, go to the emergency room. They don't want some of the things that those institutions are currently offering. They've got very smart people who work there. They have got to do something to rethink their role in society. Example, my husband was on staff at Tufts Medical Center years and years ago. Guess what? Residents used to be sent out to visit the patients in those apartment houses in Chinatown because there were old ladies there who didn't speak English or who, couldn't get down because, to the hospital and so on. They were providing a service that's as needed today as it was then. And maybe they just need to sort of have futurists sit down and think about who are we in society and what can we do better to provide the care that people actually need and want.
Excellent.
Just really quickly before we get off the hospital thing and close the event for today and give away a Fitbit, Rushika, do you have a twin who's doing hospitals? Is there somebody doing fantastic research about redesigning the hospital system that we could learn more from or look to?
I think there's some hospitals doing some good. I think the thing I find most interesting is the Plane Tree hospitals. If you've ever seen those, the movement that's got multiple hospitals around the country which have completely, again, I think the problem we've gotten into is we try to solve these big problems with little solutions. We need to be willing to solve big problems with big solutions and rethink what does it mean to be a hospital, right? And I think if I were the hospital, I would get out of the business of supplying hospital beds because because we're going to cut it by 40%, right? You don't want to be in that business anymore. What you want to be in the business, and no one wants to pay for it, right? What they want to pay for is keep me healthy and manage a population. And so you need to just rethink what business you're in. Once you do that, all of a sudden you need lots of people because that's what helps keep people out of trouble, et cetera. But it, again, requires the courage to do something big. I think what Plane Tree said is what we completely change how we think about hospitals and make it incredibly patient-focused in ways that it's, would make a lot of typical hospitals squeamish. But again, I think sometimes this thing that sometimes it's too hard to do something big to do something little, maybe that's wrong. Maybe it's too hard to do something little. We ought to have the courage to do something big.
Thank you. So we've come to the end of our time. I would like to thank our panelist Dolores for her complete willingness to always just tell it like it is. Rishika for giving us some ideas about a new way to do some things and also bringing the word empathy back into the discussion about healthcare. Meredith for being a healthcare economist who not only has knowledge about the books on the academic side but also the real world. So thank you all for being here today. And to all of you who took some time out of your workday, I know many of you took some of your own personal or vacation time to be here, so thank you for making the effort. We have a Fitbit. Meredith, you want to pull a number out?
Yeah. All right. Don't get mad at me. All right. 6867826.
All right, Leslie, all right. Thank you. We have some snacks outside, so feel free to mingle and chat and enjoy some snacks outside.